how are you today? My name is Mary Hernandez. Today I'll be talking to you about upper extremity fractures. Upper extremity fractures could occur anytime, but also it does happen to patients who have very weak bones like osteoporosis. Then there's brittleness going around inside the bone and it will break a lot faster. Some of the upper extremity trauma fractures will be tough fractures, mallet fractures, baseball fractures, Bannett's fracture, Boxer's fracture, Hutchinson, also known as Traffair, because it just happened on the side, but like it's like if you were driving. Also, we have Torres fracture, Barton's fracture, Collins fracture, and reverse Collins fracture. And the last one will be Montague fracture that also happens. This one could happen maybe you're defending yourself from something or martial arts, stuff like that. It could happen like that. And later on, I will talk to you a little bit more about how the fractures are evaluated when you get to the ER, using your technical fractures, telling you where exactly to point the center brain and how it's done. Thank you for watching. I hope you enjoy the video. Now we will continue to talk about the fractures. As I mentioned before, the first fracture will be the toe fracture. The toe fracture is a fracture that happens on a distal phalanx. This right here. You can see it better on an oblique and a PA. On the PA, the protocol most of the time is PA, oblique, and lateral. For this image, the center weight will be the PIP, which is the proximal interphalangeal joint. This right here. The SID is 40 and the KVP is 50 to 60 approximately. It's also known as a commuter fracture, and this could happen to anyone. I mean, it's very small, first of all. And as I said before, people who have osteoporosis, they could have it a lot more because they have brittle bones. Also, we have the mallet fracture. The center area will be the same, the PIP, SID 40, and KVP 60, approximately from 55 to 66 or 60, depending. And for this image, we'll be showing the entire phalanx, everything, and the metacarpal as well. And the projections are the same, PA, lateral, and oblique. As you can see here on the lateral, you can see it a lot better. This happens a lot more often to baseball players. And it's also known as an evolution fracture. The next one will be Bannett fracture. The Bannett fracture, for this particular x-ray, we should have the entire hand. I'm sorry for this picture. It's not the best one for the image. Didn't realize it was like that. The center ray will be the MCP joint. It demonstrates the entire hand, and the SID for this is 40, 55 to 60 kVp depending. And the next one is boxer's fracture. The boxer's fracture happens most of the time to boxers. That's why it's called boxer's fracture. You can see it right here. The center ray remains the same, the MCP, SID 40, and KVP 55 to 60 depending on the body habitus. But the hands are usually the same for every patient. This happens on the 5th metacarpal, as I said before. It's best visualized on a lateral, on an oblique, and then in a PA. And the next one that we will be talking about is a Hutchinson fracture, also known as a Traffair's fracture. It's like when you're driving and you stop, or they hit you by the back, and then you fracture the styling process of of the radius. For this, you need a wrist view. The views I have here are lateral and oblique, but it's also a good idea to have a PA or an AP depending on what the doctor needs for better readings. For this, we have to demonstrate the carpus, the metacarpus, the radius, and the ulna. The center ray is mid-carpal area, so I would say by here. This is a little bit off, but it will be right here. And then we'll get the metacarpals and we'll get the ulna and the radius. The SID is 40 and the KVP is from 65 to 70. And the next fracture we'll be talking about is teres fracture. The teres fracture is a round evolution. It's swelling. It usually happens on pediatric. It's most of the time on soft bones. And for this, the SID remains 40, KVP 65 to 70, and we also need to have the carpus, the ulna, and the radius on the image. The next one will be the Barton fracture. The Barton's fracture occurs on the articulation of the radial head and the carpal wrist, right here. This right here, there's a fracture. The SID will be 40. The KVP will be 65 to 70. And we need to have in the image the carpals, the metacarpals, the ulna, and the radius, like in here. Just how you have it in here, okay? Yeah. The next fracture is the Collins fracture. The Collins fracture, it happens on a displacement of the distal radius. On this image, you can see how the radius is going forward. Like that, it's moving. So we also have the reverse Collins, which is the anterior displacement, and that will be this one. The next image will be the Smith's fracture. On both of these images, the SID will still be 40, the KVP 65 to 70. The view for it, what we need to demonstrate in the image, will still be the carpals, the metacarpals, radius, and ulna. Everything is needed because, well, we need to see if there's anything else fracture other than the radius or the ulna. Then the next one and very last one will be the Montagne's fracture. This fracture occurs in the ulna. As you can see right here, it's a proximal ulna. Most of the time they do elbow x-ray, but they could also do the forearm. But the forearm will demonstrate the entire ulnar radius all the way to the hand. Most of the time they do elbow. The SID is 40, 70 to 75 kVp, and you need to demonstrate the humerus, the radius, and the ulna. The center ray for this image will be the mid elbow, and make sure that you demonstrate the proximal area. If you can, get the patient on a 90-degree, it's even better, but on this one you can't. So, and also you could also do the Heinz view, which separates, which is this view. It looks better on it to separate the ulna and the radius. That will be all for this video. Thank you for watching. I hope you enjoyed the video and you learned a lot. See you next time. Have a wonderful day.